This is Sara Johnston. I just met her last night. And I already love her. And I love the proposal that you made for this presentation, and I'm really excited to find out what Sara has to teach us. The title of this presentation is Descended Sacrum, correct?
Yes.
And Sara teaches a craniosacral training program in Chicago, and she came all the way here to do this, and let's take it away.
Thank you.
Yeah.
I've never been double mic'd before, so this is a new experience. I wanted to start out talking to you about where my interest in the sacrum came from. In this lifetime, this incarnation, I've had 3 lives, basically. And in the previous life, in this incarnation, before my healing journey began, I was an industrial worker, hard hat, work boots, working in a male environment mainly, working rotating shifts. And I was running in the Chicago winter to try to get to my unit on time because I was running a bit late. Having a child makes life complicated. So I slipped on the ice and landed fillet of sacrum. And laying there in the ice, in the snow, wondering, how am I going to get back up? I can hardly breathe. How am I going to work all day and then get to my massage school class at night? Somehow I made it through the day. Somehow I drove all the way out to where my class was, and I explained my dilemma of pain to my instructor. And she had taken a number of craniosacral classes, which I had never heard about, and worked on me in class. And I was amazed in 20 minutes how much pain was gone and how fast I was able to heal. So it got my attention. So basically what brought me to the dance of the cranial work is I fell on my ass. So that's what brought me to the dance. I want to talk for just a minute about how things happen. Information comes to us when we're ready for it and when we need it. And it's about how I found Carol Gray. This last winter in Chicago, and I know in many places in the country, was horrible. It was dark, cold, snowy, and that may have been a contributing factor. And I was getting this longing of a need for community. A student who had been referred to me, who had gone to the massage school I used to teach at, came and had a cranial session. And afterwards, we were just sitting and chit-chatting. She is a very talented young person, and she explained to me that she was going to be going to Portland, Oregon in August to take a workshop with this woman, Carol Gray. So as soon as I got home that night, I Googled Carol Gray midwife. Up pops this amazing website, and this woman who has developed this community of people in the Portland area, and I was so excited. I thought, okay, maybe I should take one of her classes just to meet her and just to get involved with this community. And then I noticed 2014 conference, Infant Maternal Craniosacral. And then I noticed a call for presenters. So I thought, she doesn't know me from a hill of beans. I'm just going to send something in. Either way, I'm going. I planned on coming to connect with this community. And 2 weeks later, I get an email back from Carol saying, you're on. So here I am. And I have never taught at a group this large. I'm so absolutely thrilled. I teach in small workshops. I think the biggest workshop I ever taught was 14. And I didn't have an assistant. And I learned that you have to have help and support. So I thank those of you who've already come forward to saying that they'll work with me on doing the hands-on portion of this. The third thing is, where did my topic come from? Our clients come to us so that they can teach us things. I got a phone call about a 4-year-old girl who had headaches, frontal headaches. And so I said, of course, come in, we have a session. So she comes in with her mother. She's a toe walker. Let's call her Charlotte, or Scarlett. Let's call her Scarlett. She comes in walking on her toes, She has multiple symptoms: frontal headaches, speech problems with certain letters, S's, T's, R's, had a terrible childbirth. It was very, very difficult for both the mother and her, and Scarlett. And they did a suction birth. And she was a colicky baby for the first 6 months of her life, never slept more than a few hours at a time, had problems keeping food down, her milk down. So they brought her to me for a frontal headache. You have to step back when you see all these different symptoms and let the dream body come to you and tell you where to start. Where do I start? So I just got really quiet, and the mother was a resource. They were telling stories and singing songs, and her dream body said, start at her sacrum. So I started there, and we worked through the whole process of an hour session. And I've been seeing Scarlett for a number of years. She no longer has a speech impediment. In fact, she can trill her R's much better than I can. I told her if I lived in Mexico, I'd have to have speech therapy. And she's doing quite well. She doesn't have the headaches anymore. We dealt with the balance question of where toe walking comes from. It doesn't come from them needing boots on their legs. It comes from the sacrum being out of place. And so their center of balance is different. So those are the three components that led me to this talk on this day at this time. So I have these lovely props that Lisa Gillespie, who will be presenting, brought me to use. This is Carol's pelvis. And this is my brain. So what is a descended sacrum exactly? If you notice, if you're looking from the side, I'll make this at an angle. Is that better? That the sacrum, as it articulates with the lumbar spine, has about a 50-degree angle. With a descended sacrum, what happens is the dural membrane is ransacked back and forth, some different events. I'm going to go through the causes, shifts so it's more acute, and lowers, so becomes descended, which creates a drag on the entire reciprocal tension membrane, the entire dural tube. Not just through the spine up to C2, but all the way through the foramen magnum, surrounding the brain, the hemispheres of the brain. Okay, so that angle sharpens and lowers, which changes the relationship spatially of balance. So if you remember when you were studying the dural tube connects at SSS, second segment of sacrum. That's an easy way. I have to have the acronyms for me to remember things. Goes all the way up. There's an attachment at C2. There's also the myelin bridge behind it, which stabilizes with fascial tendons, muscles, to stabilize this area, which is critical. And then bifurcates. The dural tube bifurcates, becomes two layers as it goes up through surrounding the inside of the bones, endosteal dura, and the hemispheres of the brain, meningeal dura. The falx, it separates the two hemispheres from the brain. Here's my brain. And the tentoria, which separates the forebrain from the hindbrain. So all of this is connected. I know that when I was first teaching cranial work, I was compartmentalizing the superior portion of the reciprocal tension membrane and the inferior portion, but I'm more and more leaning towards the brain and the spinal cord are all one. They're all the brain. And the membranes are continuous. So a drag from the descended sacrum, a drag where the base of the sacrum goes slightly interior and down. So if you think how this impacts on the functioning of the brain. I call the whole brain and the spinal cord the tadpole because its movement is like fluid, like a tadpole. We are fluid and membranous beings. We just ossify in order to support ourselves in gravity. If you look from the rear, the SI joint, sacroiliac joint, is an amazing joint. The articulation is very small. It's a small upside down L. I don't have a sacrum that I can take apart to show you. So you have these two huge bones, the ilia, and you have this central bone, the sacrum, where the joint itself is under strain because of the anterior and inferior movement of the descended sacrum. This destabilizes all the other joints in the hips. It puts a strain on the joint between the sacrum and coccyx, between the sacrum and the lumbar spine. It creates tension throughout the hips because the body has to compensate for the drag on the entire dural membrane. Yes?
Clarify something?
Yes.
You're talking about the descended brain, but what causes the descendants of the brain or brain, the sacrum? Are you talking about the trauma, like you had to slip on the ice, or are other reasons why sacrums can descend?
Absolutely. I'm going to get into that in just a couple minutes, but you're thinking in the right direction.
Okay.
Like, how does this happen? Right?
Sorry, I was premature.
No. I like it. Thank you. I like it when people are thinking and this is where we want to go. Okay. So what happens with this descended sacrum and this drag on the whole dural tube, the whole drag on the membrane, so the axis of the sacrum has changed. It's no longer at S2, so toe walkers, people with balance issues. The relationship at C2 and the connection, C2, the dens going up through between C2 and C1 is a fulcrum point for all the muscles between clavicle and hard palate, which big impact on speech, swallowing. Spitting? Yes. Spitting, kissing, everything. Then you go up through the membrane. By the way, Lisa Gillespie, who's here, did this fabulous piece on the intraspinal and intracranial membranes that was at the 2012. I don't know if it's still available for people to get. Get it. I told my students from the last workshop, if Carol Gray still has them, get it, because it's a fabulous learning piece. And it should be in every craniosacral person's hands. I think it was fabulous, and I want to thank Lisa for doing that. It's a tremendous amount of work she put into it. So the axis of the sacrum is altered. The axis of C2 is altered. The axis in the brain is altered. The brain is not able to function fully. It's not able to go through its full cranial wave of flexion and extension. And that impacts on the movement of cerebral spinal fluid, which impacts on every cell in our body. So when you restrict the brain's respiratory movement, that affects the functioning of the brain. If you remember the movement of the brain, the way I best remembered it is, you remember Bert and Ernie? Ernie with a rounded, flattened head brain, and Bert with a narrow. That's essentially the movement that the brain goes through. Ernie being flexion, Bernie being extension, and that's not able to happen in the way that it needs to happen. Ernie can't do his work with a descended sacrum. It impacts on the functioning of the falx and the tentoria. That's what little Scarlett's problem was with frontal headaches. There was a drag right at the cristagalli and the ethmoid from her descended sacrum. Frontal headaches that she had almost every day. She doesn't have them anymore, but understanding that the membranes and the functioning of the brain and the cerebrospinal fluid and the bony structures that support that are all together in one movement. Just like we're all together in one movement. You can't work one part and not work with the others. Hugh Milne talks about you can't get the head right if the heart's not right, and you can't get the heart right if the sacrum's not right. That is a simple, beautiful metaphor for exactly what the work is all about. So we talk about the strain on the joints. Also, it impacts on a strain on all the pelvic organs. When you have the sacrum moved forward anterior, it crowds all the organs within the pelvis. That, when there's a torsion or there's a lesion, like the sacrum being descended, what happens is fascia and connective tissue thicken to try to protect and stabilize. That impacts on the lymphatics of the legs. That impacts on the circulatory system, venous and arterial. Everything is congested, and you begin to develop edema in the legs, especially during pregnancy. So it impacts on every part of our functioning, and on the organs, very often on creating problems with childbirth. Then you go to the muscles. There are some midwives here, correct? People who work in that realm are just fabulous, and they know all the multitude of ligaments that are crisscrossing all across the SI joints. It's not just joints that are there, but they're layer upon layer to allow for movement and pliancy and flexibility and also strength. And there are also ligaments on the inside of the SI joint. All of these are under strain with the descended sacrum. All of the muscles in the whole pelvic region, piriformis, coccygeus, are under stress because of the inability of the sacrum to function properly in relationship to the two ilia. So very often there's sciatic pain that's involved. Then you begin to look at other muscles, psoas, functioning of the psoas. If there's a drag on the sacrum, the functioning of the psoas is impacted as well. So it not just impacts on the entire pelvis, but then it plays all the way up into the brain. What are the causes? The lovely participant asked, what are the causes? The most common cause of the descended sacrum, this bony lesion, and the most overlooked because most of the symptoms play out in the upper parts of the reciprocal tension membrane, are childbirth. The bearing down against resistance. William Sutherland noticed this in his practice, that the whole process of childbirth, especially during the times when he was practicing, there weren't as many midwives available, and there was a problem of the sacrum becoming impacted by the actual birth. I have a client, I'll call her Rebecca. She is like maybe in her early 60s, has had horrible headaches for 35 years. So she came to me out of desperation. Her daughter told her about me. Her last thing she had tried was they did an injection in her nerve in the back of her head, and now she couldn't lay her head on a pillow to sleep. So she went from 35 years of pain to not being able to sleep as well. And she came to me out of desperation. So when we were sitting and talking, I just started noticing things about her, and I started asking her questions. It turns out she had given birth to her daughter 35 years ago. And it started out as back pain that worked its way all the way up the whole dural tube, ending up as horrible headaches, and then now with the intervention of Western medicine, the inability to sleep very much. So I asked her how her back was, and she said, well, I really want you to work on my head. That's really where the problem is. And I discussed with her what I thought we should take a look at. And she mentioned, yeah, I did have my daughter 35 years ago. So I said, let's give it a try and see what we do. After the first session, I saw her a week later, and she had not had a headache all week. And she said, I cannot believe that I might have my life back. The next week, as we know with this work, it goes in cycles. Sometimes you have to go back through the pain to get rid of the pain. So that next week, it was very uneven for her. The third week, 3 days of not feeling good at all. and 4 days of absolutely no pain. So we're moving in the right direction. But I would have, if I hadn't had the other experiences in my life, I would not have noticed. I would have started with her head, because that's what she wanted me to work on. But you have to listen to the intuitive side of who you are. And it's our clients that teach us and make us grow.
If you hadn't known from your experience, but if you had paid attention to what you felt in the head, would you have been led to the sacrum anyway?
If I had felt it was, can you say it again?
I said if you hadn't known anything about sacrum to trust to go there first,
Yes.
if you'd gone to the head,
Yes.
you would have been led there anyway, right?
If I hadn't known what I know about the sacrum, and if I just went to the head first, would I have known what to do? I would have probably felt a drag. Yes, yes. So sometimes when we have false starts, that's a really good question. Sometimes when we have false starts, the dream body corrects us. It's like linear brain, shut up. Listen to the body. That's the heart of listening. That's what our work is. Could you stand up?
Can you feel it physically, and can you see it physically, a descended sacrum? So, I mean, I know that one of the ways to recognize it is from the drag, but is there a way to be able to visualize that or see it without feeling it that way from the drag?
Yes, there's a way to see it visually. Occupational therapists, PTs, they tend to measure things. So they look for the relationship between the lumbar spine and the tops of the ilia. And if it seems like it's lower than normal, then they classify it as a descended sacrum. I do better with feel. So sometimes you just put your hand on a sacrum and you just let the information come to you, and you sense what you need to do. Yeah, good question though. Okay, so it can be a contributing factor in difficulty giving birth, because when the sacrum changes its axis and moves slightly anterior and down, the head of the baby is not able to engage. Usually sacrum rolls back and the head engages, and then as the head descends, it changes. Carol can probably tell you a million times better, but that's the essence of it. So it creates a difficulty in childbirth. It limits the size of the true pelvis. And because of the whole drag on the craniosacral system and the drag on the brain, so the brain's be able to move with a cranial wave, that impacts on the limiting the actual fluctuation and movement of the cerebral spinal fluid. That impacts our entire body's functioning. It impacts on brain functioning. William Sutherland noticed in his practice how altering the cranial wave can lead to depression, neurosis, psychosis, because it alters the ability of the brain to function. He noticed this from experience he did on himself with that football helmet, where he would stop cranial movement in different places and record what was happening. But he noticed this also with clients. Postpartum depression can often be connected with a descended sacrum. I had a client who came to me in her early 60s. She started noticing pain in the back of the occiput, tingling, and she was getting tired. So she went to a neurologist who wanted to do surgery and cut open the back of her occiput. And he told her she had 2 little tonsils that were hanging down, which is the brainstem, and that they would push it back up. So we had 3 sessions, and her pain stopped, and she went back to see the neurologist. And he said, "Are you ready to have the surgery?" And she said, "No, I don't have any pain anymore." And so he asked her what she did, and he didn't believe her. But she's a believer. And we were able to save her from going through a very serious surgery, which very often does not work and creates worse conditions for people because it impacts on the functioning of the brainstem. Studies have connected. When I was... Oh, yes.
Did you say psychosis?
Yes.
Have you seen that from a sacral impact?
I haven't, but William Garner Sutherland experienced it on himself.
From the sacral?
Yeah.
Thanks.
Good question. Thank you very much. So as I was preparing for this presentation, I started doing more studying. It's like things, more information. I wanted to know more. And they're linking, they've done studies recently of linking learning disabilities with the descended sacrum because of the drag of the whole dural tube on the brain, drag on the functioning of the brain, leading to vision issues. The vision is in the back of the head, that drag on the dural tubes from the occiput. Speech impediment, my little scarlet. Headaches and migraines. And interestingly enough, temporal mandibular dysfunction. If I get someone who comes to see me who has TMD, and I learned this from Peg Johnston in the prenatal massage class years and years ago. Chinese medicine says open jaw, open pelvis. So if the pelvis is tight, the jaws are tight. When I get people with TMD, the first thing I go to is their SI joints. And I work with Piriformis, coccygeus, and very often you'll see their mouth, their mandible drop open. So when you get up to the mandible, half your work is already done. Descended sacrum can lead to inability to get pregnant sometimes because of the congestion in the whole pelvic floor and with all of the organs. It can pull the ovaries out of place, push the uterus out of place, and make a congestion so that getting pregnant can be difficult. So you've got chronically imbalanced joints, problems with the lymphatics in the circulatory system in the legs, weak pelvic floor, incontinence, many, many things all impacted by this one bony lesion and its impact on the whole dural tube and the functioning of the brain. So what I want to do with the techniques, you should have a list of techniques. I don't know if they've been passed out yet. I'll just go through them now, and they can be passed out when we set up our tables. I can just go through this real quickly. I'm going to be starting with a core link hold with the occiput and sacrum.
Sorry, could you wait until they were passed around, then we can take notes?
I'll be doing a hands-on.
Great.
Is that okay? Okay. So core link will be to start. So when you do your own hands-on practice, it can give you information and you can figure out where you want to start. Who's here? Where should you start? I'm going to be going through a sequence, but that sequence is only a teaching tool, and the technique is secondary to the process. Then I'll be going down and I'll be working through the diaphragms, pelvic floor, the bowls and domes that horizontally work our way all the way up and creating a fluidity through these diaphragms so that when I get to the work of trying to free up the membrane from the sacrum all the way up into the brain, I have a fluid field of fascia. So I'll be working through the pelvic floor, the respiratory diaphragm, thoracic inlet, and also heart unwinding. Because with traumas, there is heart pain. Then I'll be coming back down to try to coax the sacrum to get back into the dance and be free, working with a bilateral piriformis release. And if you feel so called in your work today to work on one side first and then the other, that's totally part of what we can do. Then I'll be working with a couple of holds, working with a sacral hold and a spanning technique from the ASIS, where I can sense when I'm able to make a little gapping in the back at the SI joints with a little push of creating a clothespin type opening, and coax and guide the sacrum to go back home where it belongs. The other is with a sacral hold and thenar eminence on symphysis pubis, creating a different form of gapping. Finishing up with a compression ventricle 4 and trying to, where you can work with all of the intercranial membranes and bring them into a balance. So that's our piece for today. I think we need to take a little break for a few minutes to set up tables. Could you stand up?
Sure. I only heard you give one reason so far for the descended pelvis. You just said, birthing. Like, were there other reasons, or why men or children have descended sacrum?
Yes. Thank you. So I must have slipped over that, and I'm glad you brought that up. Okay, birthing is one of the big ones. Car accidents, whiplash, where the entire membrane, dural tube, gets whipped and shoves the sacrum forward and down. Jumping from a high distance, so the ilia go up and the weight of the torso goes down. Or the opposite, carrying heavy, heavy weights that can put pressure on the pelvis, on the torso, going down in relationship to the hips and the ilia. So we'll be proceeding to setting up tables and then doing a hands-on. I think that'll still allow you to take notes when I work through the techniques. If that's not, then just take the...
We don't really have time for a break.
No, let's just do it. Karen has volunteered her body for this part of the hands-on work, so let's give Karen. So if you could, head on this end. I'm going to work through the techniques fairly quickly. This is a pretty experienced group, and we've got wonderful assistants who've volunteered, and I want you to get your hands on each other. So, no further ado. First technique I'll be doing is called core link. I'll be working with sacrum transversely, occiput, and just getting a reading on who's here. If you could lift your hips up just a tiny bit. So I'm under her sacrum with a transverse hold. My hand is neutral. It's simply creating a vessel for her to come to. Because essentially our work, we're space makers. We create a void and we create space so that the body can do its own innate, intelligent healing. I always tell my clients I'm just along for the ride. Thank you for the dance when our session is over. I'm going to slide my hand under her neck so I don't pull her hair and come under occiput. Karen volunteered because she has temporomandibular issues and she's hoping that we can fix her today. We won't have time to have a long session, but she can also join with the others and the lovely assistants here who can work with her on that. So I'm getting a read, and there are issues going on in her sacrum that are affecting her temporomandibular joints. And we will begin to touch on that with a hands-on demo, but it's the work of the rest of you to work on her during the hands-on part to complete. You can sense when you get very quiet. Talk louder? Yeah. Okay. You can sense when you get very quiet the potency of the cranial wave. And as your cranial wave slows down to do the work, you sense an entrainment with their cranial wave slowing down, becoming more potent. And her sacrum would like me to stay here a long time, but today I can't. So I'm going to slowly come out, slowly come off occiput. Now I want to work with the diaphragms to create a fluidity in the fascial, the central tendons, and pelvic floor, thoracic inlet, first respiratory diaphragm to create a fluidity so that when I begin to work with the sacrum, there's a fluid field. With my superior hand, I'm going to come under the lumbar and upper sacral portion with a transverse hold, placing my inferior hand between the two ASIS points on the ilia. And it's the kinetic energy between my two hands melding with her field that allows you to create a fluidity throughout the pelvic floor so that your work can be more effective. And again, her sacrum is very happy right now and it's pulsating. So whoever she works with today, know that that's a place you might want to start. Then I'm going to slowly come off the dream body, placing her hand at her heart, letting her dream body know we'll be getting there soon. And I slide my superior hand under the rib cage, just posterior to the respiratory diaphragm. Inferior hand just below sternum. And when you do this work with each other, just sense when the breath just sort of lets go. It's allowing you in. If you do things like holotropic breath work, this would be a time where you could engage that work with your person if it seems appropriate. I'm trying to find the right teacher for that for me in the Chicago area, which doesn't have quite as much available as the East and West Coasts or in Europe. And then I'll be moving to heart space, thoracic inlet, top of the lungs, and her breath just entrained. With this one, I tend to come at a slightly different angle so that it's comfortable for them. I can deal with heart, thoracic inlet. I can also, with my hand that's under the body, the posterior hand, create a safe vessel for the heart to just settle into. Sometimes our hearts just need a hammock, a place to rest, and to feel supported in life. So I'm going to be coming under her heart. I'm going to be putting her heart back at respiratory diaphragm. I'm going to be taking my anterior hand here, the inferior hand, connecting with heart, connecting with the fascial congestion, connecting with the mediastinum that really truly connects head and heart, the fascial hammock of the heart that goes up and connects with sphenoid. You can't get the head right if the heart's not right, and you can't get the heart right if the sacrum's not right. And her dream body loves this, having support for her heart. Feeling supported in life. Due to time constraints, I have to leave her heart now and come off slowly. I'm going to be doing a bilateral piriformis release. If you feel called to, when you're working with each other, to work one side and then the other, you can do that. It's totally what you're called to do. But I'm going to be putting my hands under waist, sliding down, connecting with the lateral edges of the piriformis at the SI joint. So finger tips to bone, pads to muscle bellies. Remembering that open jaw, open pelvis, as the pelvic muscles, the posterior muscles begin to soften, There's a direct connection between piriformis, double-bellied muscle, and lateral pterygoids. Open jaw, open pelvis. You can begin to do your temporomandibular work from here. And you wait for the dance. Muscles soften, fascia softens, joint becomes more mobile. The energetics of the sacrum, the sacred bone energetics. And again, a deep change in her breath and entrainment. And you can see the masseter muscles in her jaw just softening. That may be where your work is next. Let your left hemisphere go and follow dream body. And I'm going to slowly come off. Moving into working again with sacrum and with the ASIS holds, following the dance, and then creating a bit of like a clothespin pressure between the two ASIS to gap the back of the SI joints. Could you lift your hips? So I'm again, the split finger hold of the sacrum, the Vulcan salute. Forearm to the ASIS, finger pads to the other ASIS, and sensing the relationship between the two, the dance. And if I feel it's appropriate, I'll put a slight bit of pressure from my fingers and from my forearm. Forearms can be very sensitive. Bones are alive and have energy. And again, a change in her breath with that just slight pressure gapping the back of the SI joints. And she'd like me to stay here for a while, but I want you to get your hands on each other. So I want to use another technique to gap a different part of the SI joint. Do I have permission to touch your symphysis pubis? Could you touch it yourself first? Okay, thank you. First, I'll be laying my hand just above the symphysis pubis so that the dream body can get used to someone being there. It's not an area that is usually touched. And again, a change in her breath. Then I'm going to be taking the meaty part of my thumb, thenar eminence, and placing it firmly. This is about the most pressure I'll ever use, but placing it firmly to create a little bit of a gap in the SI joint in a different place. And again, with my hand that's underneath her, the sacral hand, I'm following the dance of the sacrum in relationship to the two SI joints in the ilia, and the lumbar spine, and the dural tube. And her heart feels deeply touched again by this. Stay with the holds. If you don't work through all of them today, this is a really intelligent group. You can get the video and pick up what little pieces you may have not been able to get to, but honor the dream body today. I'm going to slowly come off. And my final technique will be compression ventricle 4. Again, you want to have a gentle sweep coming under. If you like to do a one-handed CV4, you can do that as well if you need, your hand feels called somewhere else. It's whatever the dream body asks you to do. So I'm going to slowly come up. Sensing the line of the draw of the falx, the two tentoria, the little tent, the cerebrospinal fluid, the fourth ventricle, sensing where there's a strain or they're not in concert, following the wave, and sensing their field of chi. Hers has become more potent, somewhat freer. So for an open heart, a clear head, and a free body. That's what I learned from Hugh Milne, and that's what our work is. So if people want to get your partner, get your table set up, I'm going to stay with her for just a couple minutes, and then we'll move into everyone getting a chance to get their hands on each other. If you need any type of help whatsoever, you just look up, and someone will find you. We have about 12 minutes per rotation. Per rotation. So our first technique, once you've gotten your partner comfortable.
Did you say 12 minutes per person or?
Per person. We had so many good questions and I talked too long.
It's all good.
The first, if you remember, was core link. I'm trying to find my sacrum, where I'll be doing a transverse hold of the sacrum and the occiput, connecting up our tadpole in the home membrane system. Carol's back there organizing the assistants. Thank you very much.
Sarah, did you want the sacrum?
Core link, occiput, and sacrum. And get yourself really quiet, letting your cranial wave slow down to fluid tide, which is 2 to 3 cycles per minute. Using this hold to let their dream body entrain with yours, or their field of chi settle in with you. Using this technique as a way to sense where the drag is coming from and where your work should go. Anyone who needs an assistant, raise your hand. We have some lovely people that are very experienced and skilled that would love to help you. Sacrum is a sacred bone. Occiput Greek for back of the head, but it's where we receive support. Connecting the entire reciprocal tension membrane, sensing the position of the bones, the cranial wave in the field of chi. If you feel your work is here, stay there. Others who feel they can move forward will be working with the diaphragms of the body, starting with the pelvic bowl. With a transverse hand at sacrum, a transverse hand between the two ASIS, inside of the two ASIS, sensing the fascial tension throughout the pelvic bowl, the levator ani muscles, the ligaments and tendons of the pelvis, the organs, working with them until they soften, become fluid, enter back into the dance. You may sense trauma here. You may sense a fearful guarding. If you do, that's where your work is. You're going through the multiple layers of muscle, skin, muscle, fascia, ligaments, organs. And the dural tube begins to dance when it has some freedom. I'm getting nods where people are feeling that. If the dream body asks you to stay here, stay there. If not, we're going to slowly move our way up to the respiratory diaphragm. We'll be coming just below where the respiratory diaphragm is on the posterior and anterior portions of the torso. Our hands are fluid and soft and vessels. Once again, we're working with the fascial layers, the layers of ligaments, muscle. Sensing their breath deepening and training with yours with this contact, if it hasn't already. Following the dance, as the respiratory diaphragm softens, unwinds, allowing the fascia and connective tissue and muscles to be freer, allowing the breath to deepen. And if you feel your work is here, you stay here. The next technique we'll be moving to is the heart space and thoracic inlet. Creating a hammock in the back of the heart for the heart to just settle in and feel support. Using your anterior hand to work with all the congested area of the brachial plexus, thoracic inlet, mediastinum, that's the hammock for the heart of fascia that truly connects head and heart. It travels up, connecting with sphenoid. And if you feel there's a lot of heart work that needs to be done, then this is where your work is. Then we'll be moving to a bilateral contact with the sacrum at the level of the piriformis. Once again, going back down to the pelvis to go back down to continue our dance with the sacrum. Fingertips, middle finger landing at about the second segment of sacrum, SSS. The other finger is molding around. Tips to bone, pads to fingers, following the dance.
Is this the one you're doing?
This is a bilateral hold where you go under the waist, bring yourself down at a 45-degree angle, connecting with piriformis muscles. And if once you get there, you sense that your work is on one side first and then the other, listen to the dream body. Working through skin, muscle, the piriformis, coccygeus, the multitude of ligaments that crisscross across the SI joint and throughout the pelvis. And follow the dance. And if you feel your work is here, you stay there. Or if you feel you need to do some work with the two ilia and the sacrum and the dance together to create a bit of a gapping so that the sacrum can perhaps find its way back home at the SI joint. You can do your the split finger sacral hold with a coccyx at the heel of your hand, your nanu, Robin Williams. Hold, combined with an anterior hold of forearm at ASIS, finger pads at ASIS. Following the dance of the pelvis, and if it feels appropriate, applying just a bit of pressure between the two ASIS to gap the back of the SI joint. Or if you sense that more work is needed near the symphysis pubis, you can get their permission to work there. Keep your sacral hand where it is. Place the thenar eminence on the symphysis pubis. Let the dream body relax and welcome it. And if it feels appropriate, apply a bit of pressure to the posterior hand, towards the posterior hand with your hand that's on the symphysis pubis. Again, creating just a bit of a gap, some space to dance and move and perhaps self-correct. If you need help with either of these sacral holds, we've got lovely assistants walking around. And because of time, we have to move on. Our dream body's wondering, why are we rushing things so much? I'm going to move to the final contact, compression ventricle 4, where the meaty part of the thenar eminence, either with a one-handed CV4 or a two-handed CV4, making sure that you're on occiput and only on occiput, at least 3 finger widths posterior to the auricle of the ear. And with this hold, you can reorganize and dance with the entire intracranial membranes, helping it find balance. Many of you, if you want to practice with each other during lunch, there'll be more time available. You've gotten information from the dream body of where the work is. Give your partner a minute to come back to normal space and time, and when you can, begin the process of just transitioning to trade places so that we can quickly move through this sequence again. So when you get your partner comfortable on the table, we'll begin with the core link, sitting at the side of the table, transverse hand under sacrum, transverse hand under occiput, First contact, using this contact to dance with the dream body and sense where the drag is. So we're working with a core link hold of sacrum and occiput, hands transversely, cupping, creating vessels, so we can sense the dance, sense the cranial wave, sense the field of chi, and let the dream body tell us where the work is. So core link. Let this contact give you information of where your work is. Follow the dance. When we quiet ourselves down to a cranial cycle of perhaps 3 cycles per minute, and our partner entrains with that cycle, and you sense their cranial wave and their respiratory breathing slowing way down. We're in fluid tide, which is where we do the work. If you've gotten the information that you need and you sense the beginning of that entrainment with your partner, you can move to working with the 3 diaphragms we'll be working with in order to open up and make the entire field more fluid. Fascia fluid, connective tissue fluid, muscles fluid, giving the cranial wave an easier time. So I'll be working with the pelvic floor, hand transversely under the lumbar and top of the sacral. Hands between the 2 ilia, transversely, resting on belly. Focus is on the pelvic floor, the pelvic bowl. Following the unwinding of the fascia and connective tissue and muscle and organs. Sensing softening. Noticing how their breath is changing with this. If you feel your work is here, you stay here. Then we'll be moving up to the respiratory diaphragm, just below the sternum and the rib cage where it separates. Posterior hand connecting with kinetic energy with the anterior hand at the respiratory diaphragm. And follow the dance. Perhaps staying here until you sense a change in breath. Following the unwinding. And if you feel a guarding here or a fear, you can stay here. This is where your work will be today. The third bowl or dome we'll be working with will be the heart, the whole brachial plexus and thoracic inlet complex. Again, posterior hand, creating a vessel for the heart to settle into and feel support. The anterior hand, dancing with the heart, dancing with the opening up of space for the brachial plexus, for the thoracic inlet, dancing with the fascial hammock of the mediastinum, which truly connects the heart with the head. And if you sense a need to stay here, that's where your work will be. If the sacrum is calling you back, we'll move back down to sacrum. We'll be doing a bilateral contact with piriformis, where the piriformis connects into the sacrum. So if you put your middle finger at about the SSS, second segment of sacrum, and your other fingers fall into place, fingertips to bone, pads to muscle. And just following the connection. Sensing the dance of the muscle, the multitude of ligaments at the SI joint, both posterior and anterior. The connection between the piriformis muscles, the double belly muscle with the lateral pterygoids in the jaw and the mandible. Sensing the dance between the sacrum and mandible. Open jaw, open pelvis. And if you sense that this hold is where your work is, you stay there. The last two sacral holds, if you'd like to work through them, are again our split finger contact with sacrum, coupled with forearm and finger pads to ASIS, anterior superior iliac spine. Following the dance, and if you feel a tension back at the SI joints, you may want to do a gentle pressure, bringing the two ilia slightly closer together with your contact points, creating a beautiful, gentle gap at the SI joints in the posterior, between the ilia and the sacrum. And if that's where you need to stay, that's what your dream body will tell you. Or perhaps you feel the angle should be slightly different where the lesion is. You can keep your sacral hand where it is, get permission to make a contact with your thenar eminence at the symphysis pubis, meaty part of the heel of the thumb. Gentle pressure in and following the dance as, again, the SI joints gap with the ilia. Following the dance of the sacrum, hopefully hoping you can play a role in working with the sacrum in its dance to find its way home. This can be profoundly healing work. And you can feel long wave in the room where the synergy of the group has shifted. The group field. And if you feel it's appropriate, you can come off this contact, or if the dream body is asking you to stay, listen to that. We'll move into our final contact with the occiput, the compression ventricle 4. Those of you who are, whatever your preference is to do a one-handed CV4, compression ventricle 4, or a two-handed compression ventricle 4. It's your choice of what feels the most natural with the person you're working with. Beautiful hold where you can work with all the intracranial membranes at the same time. Working with the fourth ventricle and total relaxation of the body. Working with the tentoria, with the falx, with the movement of the cerebral spinal fluid. And with your intention, you could actually redirect cerebral spinal fluid where there's an area that feels compressed or restricted. Follow the dance. For an open heart, a clear head, and a free body. Namaste. I'd like to thank you for the long wave this group created with their care, the group synergy and group energy and the group field. Beautiful work that just totally fed my heart. So today I want to just conclude our work with the descended sacrum, its implications for many different conditions, the causes that people reminded me to bring into the workshop. Thank you so much for your questions. And I hope to see you all again. I just want to tell you all namaste. Thank you for honoring me in this work.